Okay, let's dive right into this explainer and absolutely cut through the overwhelm of endocrine emergencies. If you're prepping for your board exams, you already know how incredibly dense this material can be, right? Well, just a quick reminder, our focus today is purely for learning purposes. We're going to give you the clarity you need to recognize these life-threatening emergencies and absolutely crush your exams. We're taking all that chaos, hormones, blood sugar, water balance, and we're organizing it into a highly visual, totally manageable framework. Let's get into it. Here is our roadmap for today. We'll hit DM fundamentals, water balance with DI versus SIADH, mastering insulin types, acute complications, and then wrap up with a quick differentiation guide.
Section 1. Diabetes mellitus fundamentals.
By definition, we are looking at a fundamental error in glucose metabolism. The key distinction here? It results in either insufficient insulin, so the body's factory literally isn't producing it, or cellular resistance to insulin, meaning the factory is working fine, but the doors to the cells are jammed locked. That one fundamental difference basically dictates everything about how we treat our patients.
And when your blood is just thick with sugar, it triggers the classic 3 Ps that you absolutely have to memorize. Your body is desperately trying to flush that excess sugar out, which leads to polyuria, meaning increased urination. Naturally, because you're losing all that fluid, you get incredibly thirsty. That's polydipsia. And finally, because your cells are literally starving since they can't actually access the sugar, you get polyphagia, or increased eating.
So we really have to draw a hard line between type 1 and type 2. Look closely at type 1. These patients are completely insulin dependent and they're very prone to ketosis. A great memory trick for their treatment is the acronym DIE: diet, insulin, and exercise. But here's the absolute critical part. If they don't treat this, they will literally die without insulin. For them, insulin is the most important part of the whole shebang. On the flip side, type 2 patients are non-insulin dependent, right? They just have those resistant cells. They use that same DEI treatment, but for them, diet is the absolute game changer. We're talking calorie restriction, dividing food into 6 small meals, plus oral hypoglycemics and activity.
Section 2. Water balance. DI versus SIADH.
Now, you might be thinking, wait, isn't diabetes always about glucose? Well, that is a classic trap. Seriously, don't get tricked by this on test day. When you see the words diabetes insipidus, it has absolutely nothing to do with sugar. Historically, diabetes just meant passing a ton of fluid. So while diabetes mellitus is all about sugar, this next concept, it's entirely about water.
Here is the crucial takeaway. DI, or diabetes insipidus, is purely an ADH problem. Your antidiuretic hormone is just way too low. Because you don't have that specific hormone telling your body to retain water, you end up with massive polyuria and severe, dangerous dehydration. Now contrast that with SIADH, the syndrome of inappropriate ADH. It is the exact opposite. You have way too much ADH, meaning your body's holding on to literally every drop of water it can. You get oliguria, which is low urine output, and major fluid overload, leading to weight gain and hyponatremia. Strangely enough, though, they don't usually present with edema. So just remember, DI equals dehydration, and SIADH is the exact opposite.
Section 3. Mastering insulin types.
You need to mentally screenshot this right now. Knowing the onset, peak, and duration of these insulins will absolutely save your patients, and yeah, it will definitely save your exam score. Look at regular insulin. It kicks in at 1 hour, peaks at 2, and lasts for 4. For NPH, that intermediate, cloudy suspension, think 6, 8 to 10, and 12. Lispro is your rapid-acting insulin. You have to give this with meals because it starts working in just 15 minutes. And finally, glargine. That's your long-acting workhorse, lasting 12 to 24 hours.
Never, ever forget these 2 golden rules. Number 1, only regular insulin goes in the IV. Absolutely critical. Number 2, glargine is the safest insulin to give at bedtime. Why? Well, if you look back at its profile, it has no peak. And no peak means no sudden, terrifying drop in blood sugar while the patient sleeps. It practically eliminates the risk of nocturnal hypoglycemia. Oh, and a quick pro tip on storage, always refrigerate unopened vials. But once they're open, you don't actually need to refrigerate them if you're using them up quickly.
Section 4. Acute complications and emergencies.
Hypoglycemia is a massive danger. It usually happens from not eating enough, taking way too much insulin, or overexercising. But why are we so terrified of it? Because a severe drop in sugar can lead directly to irreversible brain damage.
Your brain desperately needs a constant supply of glucose to function.
So, sear this mnemonic into your brain right now. Drunk plus shock. It's going to help you instantly recognize hypoglycemia. Imagine someone who looks intoxicated, staggering gait, slurred speech, poor coordination. Now, add the classic symptoms of clinical shock: low blood pressure, tachycardia, clammy skin, anxiety. If your patient looks, drunk and in shock, they are hypoglycemic. If they're conscious, you give them rapid sugar immediately. Candy, juice, honey, whatever you have. Unconscious, you bypass all that and go straight to glucagon IM or IV dextrose, specifically D50.
On the flip side of that coin, we've got the hyperglycemic emergencies, DKA and HHNK.
The key differentiator here is incredibly high yield. DKA is specifically a complication of type 1 diabetes, often triggered by acute infections, stress, or maybe they skip their insulin. Remember the symptoms using the letters DKA. D for dehydration, K for ketones in the blood and urine, along with Kussmaul breathing, and A for acidosis, with that classic acetone fruity breath. The treatment? Fast IV fluids and IV regular insulin. Contrast that with HHNK, which is a type 2 complication. This is basically profound life-threatening dehydration from severe hyperglycemia, but crucially, without the acidotic state. Their skin is super dry, they have terrible turgor, they're tachycardic. The main treatment focus here is massive rehydration. Simply put, HHNK is really just DKA without the acid.
Section 5. Quick Differentiation Guide. Let's bring it all back to our water balance comparison for a second. Remember, diabetes insipidus is purely dehydration and low ADH. SIADH is the exact opposite: dangerous fluid overload, super low urine output, and way too much ADH. This final checklist distills everything we've talked about into a single, high-yield cheat sheet for when the pressure is really on. DI is dehydration. SIADH is fluid overload. DKA is your type 1 acidotic emergency with ketones. HHNK is your type 2 severe dehydration emergency, no acid. And hypoglycemia, immediately recognizable by those drunk plus shock symptoms.
So let me ask you this. If your patient presents with slurred speech, tachycardia, and clammy skin, are you reaching for insulin? Are you reaching for sugar? Think about it for a second. Understanding the catastrophic risk of brain damage from a drunk plus shock presentation means you should instantly recognize the absolute need for rapid sugar. You'd never give insulin to a patient presenting with shock-like hypoglycemic symptoms. If you got that right, you are totally ready to conquer these endocrine emergencies. Keep reviewing, trust the logic we built today, and what's your next move going to be when that timer starts on your exam? Happy studying, and thanks for joining me on this explainer.